welcome to the Brainstormer of the week. This is the video podcast series by regionalfortrainees.com Tune Into Learning. And today we are discussing the answers to week 3 question of May 2012. And we asked you which of the following does not form a boundary of the triangle of Petit. And the choices given to you were external oblique, internal oblique muscle, latissimus dorsi, and iliac crest. Obviously, the answer is internal oblique. Let's have a look at what is tap block. Tap block is an effective regional technique to block the nerve supplying the anterior abdominal wall. In particular, it blocks the anterior divisions or the anterior rami of the segmental spinal nerves from T7 to L1. The beauty of this block is that it utilizes an anatomical landmark, which is the tap plane, which lies between the transversus abdominis and the internal oblique muscle to block the spinal segmental nerves. It is an analgesic block and not an anesthetic one. Depending upon where it is performed, it can act as a field block or even as a paravertebral block, as recently shown by McDonald and colleagues. It provides somatic analgesia and does not block the visceral component of spinal nerves because that is supplied by the sympathetic chain, which is not blocked by these approach. The efficacy of this block is around 75 to 80%, and there are a minority of patients in which you may not have a good outcome with these blocks. These blocks can usually be performed in patients undergoing anterior abdominal surgeries, including laparotomy, cholecystectomy, umbilical hernias, lower segment cesarean sections, prostatectomy, and radical cystectomies. In addition, recently it's been shown that this block could be effective in providing analgesia for laparoscopic nephrectomies as well. Delving into the history of this block, the first approach to the spinal segmental nerves in the lumbar triangle was first described by Rafi in an abstract in the year 2001. Subsequently, it was McDonald Group from Ireland that showed the usage of this technique by demonstrating the spread of methylene blue dye in cadavers and establishing efficacy, and subsequently they came out with many papers in different surgeries showing efficacy of this block. In the year 2007, Hebard and his group were the first to publish the ultrasound guided approach to tap blocks, which have taken the field of providing analgesia for especially laparotomies and other kind of surgeries by storm, and it has pretty much become the standard of care at many hospitals, especially across the UK and the US. Having a look at the anatomy of segmental spinal nerves, we can see that the anterior and the posterior root, which is dorsal one being sensory and the ventral one being motor, combine to form the dorsal nerve root ganglion, which then divides into anterior and posterior rami, or the dorsal and the ventral rami, whichever way you want to have look at it. And it is the ventral rami or the anterior rami that continues downwards and laterally around the abdominal wall to become the segmented spinal nerves. And therefore, the anterior rami innervate the anterior abdominal wall, which is the area of focus for the anesthetist in such cases. What can also be noticed is that there is a facial sheath between the external oblique and the internal oblique, and the internal oblique and the transversus abdominalis muscle, and it is the latter facial sheath where the nerves tread. From T6 to T9, the segmental nerves enter more medially to the anterior axillary line, which means that these segmental nerves may not be present in the tap plane at the mid-axillary line, and therefore if you deposit a local anesthetic there, you may not be able to block these nerves because these nerves have not yet entered the tap plane, whereas the nerves which lie from T9 to L1 have entered the tap plane before coming to the anterior axillary line, which is lateral to the anterior axillary line. and therefore some of the papers have shown that the efficacy of the TAP blocks may be limited to lower abdominal surgeries only, and supraumbilical surgeries or supraumbilical incisions may not be amenable to pain relief using this approach. Let's have a closer look at how these nerves are related to the abdominal muscles. We can see that the anterior rami of the segmental spinal nerve courses laterally, treading posterior to the quadratus lumborum, which is not seen in this diagram, and the posterior rami or the dorsal rami goes posteriorly towards the erector spinal muscle, dividing into a medial and lateral branches. As the anterior rami courses laterally, it enters the transversus abdominis plane between the innermost muscle, which can be seen here, which is transversus abdominis, and the middle muscle, which is the internal oblique, coursing laterally to become the proper segmental nerve. Here, near about the mid-axillary line, it gives a lateral cutaneous nerve, which is the lateral branch, and supplies the lateral aspect of the abdominal wall, and rest of it courses anteriorly, eventually to pierce the rectus muscle to enter the subcutaneous tissue in the midline as anterior cutaneous nerves, and which are the main nerves responsible for causing pain in midline incisions during abdominal surgeries. Having another look at the abdominal wall, it can be seen here that the segmental spinal nerves, shown in yellow color here, course laterally initially and then course anteromedially towards the midline of the anterior abdominal wall, and therefore these nerves can be better blocked at a small anatomical junction which allows access to transverse abdominis plane, and this junction is called the triangle of Petit, which is bounded posteriorly by the latissimus dorsi, bounded anteriorly by the external oblique muscle and the external oblique aponeurosis, and bounded inferiorly by the iliac crest. There is slight controversy as to what is the constituent of this space, and especially what is the floor of this space. Is the floor the internal oblique muscle, or is the floor external oblique aponeurosis? Different sources show different answers, but what is important to know is that there is a small deficiency in the abdominal musculature which can be exploited to our advantage by putting a needle through this and accessing the transversus abdominis plane where the nerves come together. A cross-sectional view through the abdominal here in this diagram shows very nicely where the muscles are situated in relationship to the vertebrae. So right next to the vertebrae you can see the quadratus lumborum, and posteriorly you can see the rectus spinae, and just anterolaterally you can see psoas muscle, whereas lateral abdominal wall constitutes from inwards to outwards transversus abdominis, internal oblique and external oblique muscle, followed by subcutaneous tissue, and this is where the lumbus, the triangle of Petit, is situated, where we can put our needle and access the transversus abdominis plane. Obviously, the first and easiest technique to perform is a landmark technique, which requires first the identification of the structures. What you need to do is to palpate the iliac crest and also to palpate the boundary of the rib cage, the inferior boundary of the rib cage. What can be seen is as you palpate from posteriorly and come up on the iliac crest, you would be able to appreciate the posterior boundary of the latissimus dorsi muscle, which roughly helps you to guide where the triangle of Petit may be situated. It is difficult to appreciate the posterior boundary of external oblique muscle, and therefore you might have to rely more upon the anterior boundary of the latissimus dorsi muscle. As you do this, you would then dip your finger in this particular triangle, and around this area you can insert your blunt tip needle into this triangle, trying to get the two pops and putting some local anesthetic in there, and the two pops being the first pop being the pop of the external oblique aponeurosis, or the external oblique muscle, and the second pop being the internal oblique aponeurosis or the internal oblique muscle. And therefore, at the end of the second pop, your needle is expected to lie between the internal oblique and the transversus abdominis, as can be seen in this diagram. And once you instill local anesthetic there, you should effectively be able to block the spinal segmental nerves which transverse laterally through that particular area. This is the volume block, so you would perhaps need about 20 mils of local anesthetic on each side, and therefore my choice would be to do 40 mil 0.25% bupivacaine, plain bupivacaine solution for a single shot block. And if I were using infusions, which is uncommon, you would probably use a rate of about 3 to 5 mils per hour of infusion of 0.125% bupivacaine on each side. I would expect a duration of about 6 to 12 hours from single shot blocks and a success of about 75 to 80% with this block. Thank you very much, guys. If you like this presentation, please do share with other colleagues and friends, as variously available on my website. Thanks a lot. This is regionalfortrainees.com. Tune into learning.